From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA podcast on the subject of sexually transmitted infections. I am Mary McDermott, a deputy editor at JAMA. Today, I'll be speaking with Dr. Khalil Ghanem, and we'll be talking about Dr. Ghanem's review in JAMA regarding the diagnosis and treatment of sexually transmitted diseases. Welcome, Dr. Ghanem, and would you begin by introducing yourself, please?
Thank you so much for having me. My name is Khalil Ghanem, and I am a professor in the Department of Medicine and the Division of Infectious Diseases at Johns Hopkins in Baltimore, Maryland.
Thank you, Dr. Ghanem, and thank you for joining us today. Can we start by having you discuss a bit about how common sexually transmitted infections are in the United States and why they're important for clinicians to recognize and treat?
Absolutely. So these infections are very common. So the latest estimates from the CDC suggest that in 2018, there were 27 million new infections in the United States and 68 million existing or prevalent infections. And so on any given day in 2018 in the United States, 1 in 5 people had a sexually transmitted infection. And so they're important for several reasons. The first is that they have individual consequences. And then the second one is they have public health consequences. For example, they facilitate HIV transmission and acquisition. They have a negative impact on reproductive health, resulting in, for example, infertility and devastating fetal and neonatal sequelae. So they're common and they have important sequelae for individuals and for the public health in general.
Thank you. And your review covered multiple sexually transmitted infections, and it covered gonorrhea, chlamydia, syphilis, Mycoplasma, genitalium, trichomoniasis, and genital herpes. Could you talk just a little bit about the epidemiology of those infections and how it may have changed over time?
Yeah, absolutely. If you look at these sexually transmitted infections overall, for the ones that are reportable, we have good epidemiological data. And the epidemiological data for most of these infections, namely gonorrhea, chlamydia, and syphilis, we're seeing increases in the rates of these infections. And for syphilis, for example, the rates have been increasing since 2000, and they've increased for the last 21 years. Whereas for gonorrhea, we had reached a nadir in 2009, some of the lowest recorded numbers in the United States. And yet, since 2009, the rates have been increasing exponentially, you might even say, in both sexes. Chlamydia has been steadily increasing for the past 20 years. Mycoplasma genitalium is not a reportable infection. And as such, we don't know exactly what is happening with the rates over time. And so we have much more limited data on the epidemiology of Mycoplasma genitalium. Similarly, trichomoniasis, it's not a reportable infection. And so we have more limited data and more limited time trend data as well. Finally, genital herpes is probably one of the only major sexually transmitted infections where the data suggests that it has been decreasing. And these data now, while genital herpes is not a reportable infection, we do have robust data from the NHANES studies that have been done in the United States. And these suggest that at least for HSV2, the rate has been steadily decreasing over time.
Now, I'd like to go into a little more detail about the individual infections, and perhaps we could start with gonorrhea. So, can you tell us who is at risk for gonorrhea and what are the common presenting symptoms?
So young people, particularly in the 20 to 24 age group, and African Americans, they bear the greatest burden of this infection. But certainly there are other populations that are also affected. So people diagnosed with an STI recently, people with a new sex partner or more than one sex partner, people who report transactional sex or commercial sex work, sexually active sexual and gender minorities, such as men who have sex with men, all of these individuals are at increased risk of gonorrhea infection. And the presenting symptoms of gonorrhea depend on the anatomy of the person and the location of the infection. But let me first start by saying that most of these infections that we're talking about are completely asymptomatic. Recall that gonorrhea can infect the throat, it can infect the rectum, it can infect the urogenital tract and the conjunctiva. And when you're thinking about symptoms or the lack thereof, infections, for example, of the throat and the rectum, and we refer to these as extragenital infections, up to 90%, if not 90+% of these infections are asymptomatic. When you think about urogenital infections with gonorrhea, in women, the majority by far are asymptomatic. And in men, although this is a bit debatable, a significant number, maybe about 50 to 60%, are also asymptomatic at the urogenital site. And so when we talk about symptoms, I want to remind, I think, people that we are talking about a minority of infections, and the majority of these infections, whether it be for gonorrhea, for chlamydia, for trichomonas, for herpes, they are asymptomatic. Now, when patients do have symptoms, then it really depends on the anatomy. So, for example, the common symptoms are symptoms of urethritis, symptoms of cervicitis. A feared complication would be pelvic inflammatory disease. And then another feared complication with gonorrhea is related to dissemination of the infection from mucosal sites systemically, and that's disseminated gonococcal infection. And so often patients will present complaining of, for example, a penile discharge or a vaginal discharge that actually originates in the cervix. They may also present complaining of abdominal pain, fevers, chills, and with disseminated gonococcal infections, they can present with a rash, with tenosynovitis, with frank arthritis, asymmetric arthritis, and in rare instances, endocarditis and meningitis.
And how do you recommend that gonorrhea be diagnosed when it is suspected, and perhaps comment on the fact that it's frequently asymptomatic in the context of diagnosis?
That's right. So when I say screening from now on, what I mean is that we are testing individuals who don't have symptoms. And so when we are testing for gonorrhea, the main tests that are used right now are the nucleic acid amplification tests, which have by far the highest sensitivity and specificity. But culture is still important for the diagnosis of gonorrhea, mainly, although it has a lower sensitivity, culture is still very important because it is the only way right now that you can obtain antimicrobial susceptibility information about the infection that you're treating. So right now, most places are using nucleic acid amplification tests. And as a reminder, when you're performing nucleic acid amplification tests, you can obtain many different specimens. Amongst individuals with a penis, a first catch urine is probably considered to be the most appropriate specimen. And remember, with first catch urine, you're obtaining, unlike with a urinalysis, you're obtaining the first 20 cc's or so of urine that are produced, and preferably either the first urine of the day or urine that is obtained after a patient has refrained from urination for about 1 to 2 hours. And so first catch urine is the best sample, but certainly you can also obtain a urethral swab and send it for NATS testing. So amongst individuals with a vagina, then you can obtain a vaginal swab, and that is in fact the preferred specimen. And recall that a vaginal swab can either be obtained by a clinician or they can be self-collected. And self-collected specimens perform just as well as clinician-collected specimen. In addition to vaginal swabs, one can obtain an endocervical swab, but that requires a clinical examination. And of course, first catch urine is also acceptable. And finally, a Pap smear liquid medium can also be tested via nucleic acid amplification testing for gonorrhea. For culture, it's a little bit different. For culture, the only specimens that are appropriate are either urethral specimens or endocervical specimens. So urine is not appropriate. Vaginal swabs are not appropriate. And again, cultures are mainly used these days to check for antimicrobial susceptibility of that organism.
Speaking of antimicrobial susceptibility, what are the currently recommended treatments for gonorrhea?
So that's changing, and that actually recently changed. So for many years, we had been using both a combination of ceftriaxone, IM 250 milligrams, plus a single dose of azithromycin, 500 milligrams. In December of 2021, the CDC changed their recommendation for two reasons. The first, because of increasing macrolide resistance, and the second, to enhance antimicrobial stewardship. For the sake of antimicrobial stewardship, they decided to do away with the azithromycin for the treatment specifically of gonorrhea. And now the treatment of gonorrhea consists of a single agent, and that is ceftriaxone at a higher dose, a dose of 500 milligrams IM times one. And so the new recommendations are ceftriaxone as a single dose. Alternate treatments are available, but mainly for non-pharyngeal infections. And those alternate agents include the oral cephalosporin cefixime. It used to be 400 milligrams, but now the new recommendations are 800 milligrams. So it's 800 milligrams single dose of cefixime. And finally, the only option that is available when somebody does not tolerate cephalosporins, is allergic to cephalosporins, the only option that's available is the combination of azithromycin 2 grams orally and gentamicin 5 milligrams per kilograms intramuscularly. That is the only available option when somebody cannot tolerate cephalosporins. Now, for pharyngeal infections, there are no alternate regimens. Ceftriaxone is the only recommended regimen to treat pharyngeal infections.
Let's move on to discuss chlamydia. And can you discuss how chlamydia typically presents and perhaps how that is distinguished from gonorrhea?
Sure. So gonorrhea and chlamydia can present very similarly. Again, remember, as I started with gonorrhea by saying that the majority of infections are asymptomatic, that is the same and perhaps even more likely with chlamydia. The majority of infections, whether urogenital or certainly extragenital, are asymptomatic with chlamydia. When symptoms are there, they are very similar to gonorrhea. You may experience urethritis-related symptoms, cervicitis-related symptoms, pelvic inflammatory disease as well is observed in patients with chlamydia. Those are the most common symptoms. Now, if individuals are infected at the throat and they have symptoms, then they're going to have symptoms of pharyngitis, and that applies as well to gonorrhea. And if they're infected in the rectum, just like gonorrhea, and if they have symptoms, they're going to have symptoms of proctitis. So pain on defecation, sometimes they can have a discharge that's related to that. It can be very difficult to distinguish between gonorrhea and chlamydia clinically. And so if you are taking care of patients and you are taking care of them and you're trying to treat them and you don't have any diagnostic testing that's available, and so in these patients you're treating them syndromically, then you would treat for both gonorrhea and chlamydia. And in general, when you're taking care of a patient and a patient presents with symptoms, you don't have access to immediate results for diagnostic tests. Invariably, you wind up treating those patients for both gonorrhea and chlamydia.
And if one does do diagnostic testing for chlamydia, then what test do you recommend?
So the only tests that are really used for the chlamydia diagnosis are the nucleic acid amplification tests. And it is very similar to what we talked about previously for gonorrhea. While there is culture for chlamydia, culture is very difficult to perform. Very few laboratories do culture, and the sensitivity is significantly limited. And so culture, for all intents and purposes, is not used. So nucleic acid amplification tests are the way to go. And the same approach is used for both chlamydia and gonorrhea. So vaginal swabs are preferred, or first catch urine are preferred specimens, but endocervical and urethral specimens are also appropriate.
And what treatments are recommended for chlamydia now?
So that has changed with the recent 2021 STI treatment guidelines. In the past, both doxycycline for a week and azithromycin 1 gram single dose were primary options to treat chlamydia. But because of 3 recent trials that have been published, the recommendation now is favoring the use of doxycycline for the treatment of chlamydia. So if a patient presents with urogenital chlamydia, the recommendation is to treat with doxycycline for 1 week, and that's the preferred regimen. Alternate regimen includes azithromycin 1 gram single dose. And the CDC acknowledges that if you're dealing with a patient where the likelihood that this patient will adhere to the 1 week therapy is limited for whatever reason, then certainly you can use azithromycin for the treatment of chlamydia infections. Now, for urogenital infections, the efficacy difference between doxycycline and azithromycin is very small. So there's a 3% efficacy difference that favors the use of doxycycline. So clinically, it's not a significant difference, and one can use either azithromycin or doxycycline in a way that would not elicit any concerns. However, for proctitis, chlamydia proctitis, there have been 2 trials that have been published in the last year, and both trials essentially demonstrate the same findings. The efficacy difference between doxy and azithromycin was 20%, and it favored the use of doxycycline for chlamydia proctitis. And so for proctitis, I think the recommendation to using doxycycline is a strong one. For urogenital chlamydia, doxy is better, but if there are concerns with adherence or any intolerance to doxycycline, I think azithromycin is just fine in that situation.
Mycoplasma genitalium is a recently described sexually transmitted infection. And so, can you tell our listeners a little bit about it? What should primary care clinicians know?
Absolutely. So Mycoplasma genitalium is indeed a recently described STI. I mean, we became aware of it in the 1980s, but over the last maybe 7 to 10 years, we have started to link Mycoplasma genitalium with distinct clinical manifestations. And the clinical manifestations that it's linked to with solid epidemiological data are urethritis and cervicitis. There are some emerging data on linking it to proctitis perhaps, and emerging data on linking it to pelvic inflammatory disease and infertility, but these are still limited. And so again, Mycoplasma genitalium causes both urethritis and cervicitis. In the guidelines now, they refer to it as persistent or recurrent urethritis or persistent and recurrent cervicitis. And the reason why they refer to it as such is because essentially you are treating individuals, you are testing individuals for gonorrhea and chlamydia and treating them for gonorrhea and chlamydia. If those individuals have persistent symptoms, or if their testing for gonorrhea and chlamydia is negative and they have persistent symptoms, then you should think about Mycoplasma genitalium in that setting, and you should be testing for Mycoplasma genitalium in that setting. The recommendation is not to screen for Mycoplasma genitalium. So somebody who does not have any symptoms should not be tested for Mycoplasma genitalium. And also the recommendation is not to test at the throat or at the rectum. So it's only urogenital testing, and urogenital testing is conducted by essentially an FDA-cleared test that can be performed on either a vaginal swab, an endocervical swab, or first catch urine. And it is highly sensitive and highly specific.
And how is Mycoplasma genitalium treated?
Yeah, that's a big problem. Just like gonorrhea, Mycoplasma genitalium, the big problem relating to Mycoplasma genitalium is drug resistance. And so in the past, the vast majority of Mycoplasma genitalium strains were sensitive to the macrolides. But recently, that has changed significantly. In some parts of the country, it's 90+% resistance to the macrolides, but in other parts, it's about 50%. And so right now, the treatment of Mycoplasma genitalium is a bit tricky. The recommendation is to start with doxycycline for a week and then use a second antibiotic. Now, the first question is, why should you start with doxycycline? Doxycycline will only eradicate or cure about 30% of patients who have Mycoplasma genitalium. So why use it at all? The reason is there are limited data, and I stress limited data, to suggest that by using doxycycline, it can decrease the bacterial load of that infection. And subsequently, when you use a more definitive antibiotic to treat Mycoplasma genitalium, you are likely to have better outcomes. This is, again, based on limited data, a single study. There was a historical control group in that study, and so the data are fairly limited. But because of these data, the CDC recommends that you start with doxycycline for a week, 1 week of doxycycline, and then you follow that with either azithromycin or moxifloxacin. And you would choose based on whether you know if the organism is sensitive or resistant to the azithromycin. If you don't know, or if you don't have access to resistance testing, then you should always use moxifloxacin, 400 milligrams once a day for 1 week. So it would be doxy for a week, followed by moxifloxacin for a week. If you have access to resistance testing, and I'll just mention here that resistance testing is not FDA cleared, but some laboratories are able to perform it. If you have access to resistance testing, then the test result will come back. It will tell you that the organism is, let's say, sensitive to the macrolides. Then you can start with doxycycline 1 week, followed by a course of azithromycin. So depending on whether you know the resistance profile of that bug, you will go from doxycycline to either moxifloxacin or azithromycin. It's complicated, and other countries approach this differently because they have routine access to molecular resistance testing for this organism. In the United States, those assays have not yet been FDA cleared, but we expect that they will be in the next year or two.
Dr. Ghanem, I wonder if you could next discuss diagnosing syphilis. It's always somewhat complicated, and there are multiple tests that can be used. So how would you recommend that a primary care clinician think about the diagnosis of syphilis?
Yeah, absolutely. So first, what I tell everybody is the diagnosis of syphilis is not complicated. If you have a lesion at the time that the patient presents, then your two options are either dark field microscopy, which very few people have access to, or PCR testing. And PCR is very sensitive, it's very specific, but it's not FDA cleared. Some of the larger commercial laboratories do provide it on a routine basis, though. Now, most people, when they're taking care of patients who have syphilis, they have access mainly to serologies. And remember, with serologies, there are two different types of serological tests. There are the treponemal antibody tests, and those are specific for Treponema pallidum. And then you have the non-treponemal lipoidal or antiphospholipid antibodies. And those, while not specific for Treponema pallidum, are critical in the management of syphilis because they give you a titer. So you can follow those titers and decide which way you think the patient is going. If after treatment the titers goes down, then you know the patient is improving. Or if the titer goes up, then either the patient is experiencing treatment failure or the patient is experiencing reinfection. And so the combination of both of these antibodies is the way to make a diagnosis of syphilis. Now, there are rules for each one of these antibodies that clinicians need to be aware of to be able to correctly determine where that patient is with respect to syphilis infection. And the good thing is, in this paper that we wrote, we have a nice diagram that takes clinical clinicians through the process of interpreting these tests. Now, for the diagnosis of syphilis, you can either start with a non-treponemal test, and that's usually called the traditional algorithm, or you can start with a treponemal test, and that's called the reverse sequence algorithm. Both algorithms are fantastic. Both algorithms will get you where you need to go. It just depends on the laboratory that you're using. The reverse sequence algorithm makes financial sense to use for laboratories, particularly if they are doing a lot of tests for syphilis. Smaller laboratories often prefer to use the traditional algorithm. But whichever algorithm you choose, you can go through the algorithms and essentially interpret those test results. And like I said, in the paper, we have an algorithm that essentially explains each step of the way and gives clinicians a way to interpret the test results, no matter which algorithm is used.
What is the first-line therapy for syphilis in 2022?
So in 2022, the first-line therapy is the same as in the 1940s or 50s. It is still penicillin. So unlike gonorrhea and Mycoplasma genitalium, we have not experienced antimicrobial resistance with syphilis, and penicillin is still the drug of choice for all stages of syphilis, for all patients who have syphilis. And it should always be used preferentially. In certain circumstances, alternate agents are acceptable, and these alternate agents include doxycycline and ceftriaxone. But I think the take-home message is that penicillin is still the drug of choice, and it's still the only choice for persons who are pregnant.
Let's move on to trichomonas. And I wonder if you could tell us, please, how does trichomonas typically present, and what do you recommend for the diagnosis?
So trichomonas has been for a long time the neglected STI, even though it's the third most prevalent STI that we encounter. And trichomoniasis usually presents, again, 70% of infections are asymptomatic, but when it is symptomatic, patients will usually present with either a vaginitis or a urethritis. So it's vaginitis and urethritis are the main clinical manifestations. Rarely trichomonas is able to cause a cervicitis picture. The diagnosis of trichomonas follows the same line of diagnostics as gonorrhea and chlamydia. The preferred diagnostic are the nucleic acid amplification tests. I'll just mention here that nucleic acid amplification tests are FDA cleared for women. They are not FDA cleared for men, but most laboratories have done in-house validation assays, and so we can still use them for diagnosing trichomonas in men. And again, the same specimens are recommended, either a first catch urine or a self-collected or clinician-collected vaginal swab. Nucleic acid amplification tests have excellent sensitivity and specificity and are highly reliable. There are point of care tests for trichomonas. The cheapest one is the wet mount, and that's essentially obtaining a specimen, immediately putting it on a slide, and then looking under the microscope to look for the organisms. As you can imagine, the sensitivity is actually low. Even in the best circumstances, the sensitivity does not exceed 70%, and this is for symptomatic individuals. For asymptomatic individuals, the wet mount has essentially a very poor sensitivity, and nucleic acid amplification testing is the best. Other point of care tests are available, and they have reasonable sensitivities and specificities, but they are rarely used. And then finally, culture is available, and most of the time culture is used for antimicrobial susceptibility testing, and otherwise it's rarely used. So the most common tests that are used are nucleic acid amplification tests.
And what are the first-line therapies for trichomonas?
So the nitroimidazoles are the first-line therapies for trichomonas, and the nitroimidazoles essentially are the drugs like metronidazole or tinidazole. And metronidazole is used routinely. In men, you can use 2 grams single-dose metronidazole. In women, that is not as effective, and so the recommendation when treating women is 1 week of metronidazole, 500 milligrams twice a day orally. So metronidazole is is the preferred regimen. Tinidazole is excellent as well. Tinidazole for both men and women, a 2-gram single dose is appropriate, mainly because tinidazole achieves higher tissue concentrations, and so 2 grams appears to be appropriate for both men and women.
Let's move to discussing herpes simplex virus infections. And could you start by explaining the difference between HSV1 and HSV2?
Sure. So both HSV1 and HSV2 cause genital herpes. Now, HSV2 predominantly causes genital herpes. And so when you find antibodies to HSV2 in the blood, you can reliably tell the patient that they have genital herpes. It rarely causes oral labial infections. On the other hand, HSV1 can cause genital herpes, but it can also cause oral labial infections. So when you find antibodies in the blood for HSV1, you don't know whether the patient has oral labial infection or genital infection. The other big difference between the two is the likelihood and severity of recurrences. The primary infection with HSV1 and HSV2 is indistinguishable. There's no way to clinically tell whether you're infected with type 1 or type 2. You have to test the patient and then you'll know. But subsequently, HSV2 tends to cause more severe and more frequent reactivations. And so that's one of the other main differences between HSV1 and HSV2.
And are there other methods of diagnosis that you recommend besides checking for antibody titers in the blood?
So, in fact, when you have lesions, the best method to use is essentially a nucleic acid amplification test, which is a PCR. And that has the highest sensitivity and specificity, and it distinguishes between type 1 and type 2. So if a patient comes in with a lesion, always get a PCR. Now, you can also obtain cultures, but cultures are mainly used, again, for antiviral susceptibility testing. Culture sensitivity is much less than PCR. It's about only 70%. But if you only have access to cultures, then by all means use the culture when a patient has a lesion. So when a patient has a lesion, it's either a PCR or culture. When patients don't have lesions, that's when you should consider the use of serological testing. But serological testing has a lot of issues related to it. The serological tests, while useful, have issues related to specificity for HSV2 serological tests and sensitivity for HSV1 serological tests. And I will highlight here briefly, we discussed this in the paper extensively, but I will highlight here that the recommendations in 2021 have changed for HSV2 serological testing. Now, when you get a positive result for HSV2 serologies, the next step is to look at the index values of the EIA, and that index value is a number. If that number is less than 3, the recommendation is to do a second test as a confirmatory test. And so now you have to look at the index values for all positive serological tests for HSV2. And if they fall below 3, a second confirmatory test has to be done because the rates of false positives when the index value is less than 3 is very high. So I think clinicians have to think carefully before they order these tests, and they should really order these tests in certain circumstances. For example, when they think that the likelihood that a patient has herpes is moderate to high. If it's a low likelihood that a patient has herpes, if the patient has only had one sex partner, they've never had symptoms, it's probably best to avoid routine testing. But if they do test, then they need to interpret the results very carefully.
And what therapy do you recommend for the herpes simplex viruses?
Unfortunately, there is no curative therapy, and the same antivirals have been available for many, many years. Those antivirals work to decrease the severity of symptoms and the duration of symptoms. Acyclovir, valacyclovir, famciclovir, they're pretty much equivalent. The only differences are the cost and the frequency of taking pills, but overall they work just as well. And unfortunately, they are not, or they do not offer the possibility of cure.
Thank you very much for the informative discussion of the sexually transmitted infections, Dr. Ghanem. I wonder if you could tell us about what we can expect in the coming years regarding these infections in terms of novel diagnostic methods or novel treatments.
Absolutely. So I think for gonorrhea and Mycoplasma genitalium, we're going to have FDA cleared molecular tests that allow us to detect the presence of mutations that confer antimicrobial resistance to one or more classes of antibiotics. And that's going to be really important because it's going to give us more options to potentially treat patients with drug-resistant gonorrhea or with drug-resistant Mycoplasma genitalium. I think a huge change will be the home collection of specimens. I think the COVID-19 epidemic has clearly shown that we need to think about ways to collect specimens that occur outside of the clinic setting, and home collection is a very useful way. Patients collect the specimens at home and mail it to the lab for testing. There are still some regulatory issues to iron out, but it has to move forward, and it will likely happen in the next few years. I think we're going to see more and better and faster point of care tests for many of these infections. And then finally, I'm an optimist here, but I'm hoping that we're going to see some efficacious vaccines. It may not be in the next 3 years, but maybe in the next 5 to 10 years. There is hope for some vaccines for chlamydia, for herpes simplex virus, and for gonorrhea. And I think we're starting to identify targets specifically against syphilis. So I'm hopeful, but I think this is going to take a little bit longer.
Is there anything else that you would like to add?
So I'd like to briefly add 2 points. First, the CDC has funded a free online consultation service available to all US-based clinicians to answer any clinical questions related to STIs within hours of receiving them. This is run by the National Network of Prevention Training Centers funded by the CDC, and the link is in the supplementary table in our article. Finally, I think we have to keep in mind that better diagnostics, better therapeutics, and even highly effective vaccines, while great, they're not going to be the definitive answers to the STI epidemic. The primary drivers of these infections is stigma, and the only way to mitigate the effects of stigma is to move away from the disease model to the health model. In other words, we have to focus on promoting sexual health. I want to end on a positive note. There has been a seismic shift in the United States that's taking us in that direction, and that has to do with the release last year by the National Academy of Medicine of a report whose title is STIs, Adopting a Sexual Health Paradigm. That report is actually referenced in our paper, and I would urge clinicians to download it. It's free of charge because it is really a seismic change in the way we think about managing sexual health in general and the way we should be approaching the management of STIs within the broader topic of sexual health.
Thank you so much, Dr. Ghanem, for your really informative summary of diagnosis and treatment of sexually transmitted infections. This podcast goes along with a review article published in JAMA, January 11th, 2022, on the topic of diagnosis and treatment of sexually transmitted infections. This episode was produced by Jesse McQuarters at the JAMA Network. The audio team here also includes Daniel Morrow, Shelley Steffens, Lisa Hardin, Audrey Foreman, and Mary Lynn Furkaluk. Robert Golub is the Executive Deputy Editor for Digital Media. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.